All right, we're with Jonathan Sandberg. Dr. Sandberg's a professor at Brigham Young University and is a, why don't you tell me what your credentials are in EFT, emotionally focused therapy?
I'm a certified EFT therapist and a certified EFT supervisor.
Okay, so and you've done research in this area as well. So one of the things I think some of us are interested in is how do we negotiate that intersection between our clinical practice and our research interests?
Sure. So I think the thing that helped me with that is in my doctoral training with Rick Miller for our outcome research class, we actually did a paper reviewing all of the MFT outcome research, and it was shocking to me. And that really got me thinking about, wow, we do good stuff. I know we do. I've seen it in the room. I've worked with people about.
What was the shocking part?
No, there's no research. I mean, there's no empirical research.
MFTs are not doing empirical research on our treatment.
And in that time in '96, there really wasn't any research. I mean, there's behavioral stuff for schizophrenia, families with schizophrenia, and then EFT, and then there was nothing else. I mean, there was really nothing else. And so we started doing some little things at Syracuse when I was first there using the clinic data set. And a couple of studies that I was most proud to be a part of were the experience of African American families in therapy who came to our clinic, 2 different studies there. And so what I started thinking about in terms of the therapy we provide is what makes our work good and unique. And then when I started getting DFT, what really struck me was that I think that we treat attachment. That's really what we're doing. The core connection that we want to have to other people. That's what we deal with in family therapy.
That's our domain, separate from psychology or social work or other clinical venues.
Right. And particularly, lots of folks in psychology think of as attachment as a style of relating, and I see attachment as a habitual way of connecting with others based upon previous positive experiences or trauma. So some of the work that we're doing right now that I'm most excited about is seeing how attachment is related to things that really matter. So for example, I have a study that we're proposing right now with someone that we're just starting, which is looking at attachment in current relationships affecting video game use, porn use, screen time.
And technology.
Yeah, which I think is a huge threat to current relationships that didn't even exist 20 years ago when I started. Another one that I'm quite excited about is we bring a couple into a lab working with our neuropsych friends, and what we do is we have the couple remember or recall an attachment bonding moment or remember or recall attachment injury. Kind of like in the other studies I've done, they have a 10-minute dialogue, which we videotape, but we're monitoring blood pressure while that's occurring. Then at the same time also what we're doing is, and I think this is really exciting, is our neuropsych friends are having them run through a battery of neuropsych tests right afterwards and looking at event error negativity, which is not only the mistakes you make, but your experience of making mistakes in the brain. And so we think after someone remembers an attachment injury, they're going to be spiked there in terms of their negativity. So how does that apply clinically? What all of those attachment studies do is they say that, look, if we can create a healing moment in therapy, then we're going to affect biology as well as the family relationship. And so for me, it's taking core principles that are central to clinical practice and studying them in either 2 ways. One, doing kind of the basic research to say any therapy that can help these core injuries improve is good, or the actual work of working with people in therapy and saying, what was your experience like? Which part of therapy helped you the most? Why was it effective? Of which I've done both. And I think they're both important. I'm just really into the attachment field right now.
Right. But one of the things that you did, Jonathan, was that you identified that what our core identity is.
Yeah.
So if we're going to have a conversation about the intersection of MFT, clinical practice, and research, my guess is there are probably some people who still don't really know what the core of MFT is, or that might be a debatable.
Sure, people don't agree with me.
Yeah, you've identified it as attachment, or I might say how we facilitate intimacy and connection. But other people might disagree with that. We're systemic consultants. We are but for you, locking in. I mean, at least identifying who you are, your professional identity, points you to your research that will that happens at that place of clinical practice and research.
And the 2 things I like about EFT is when I read the attachment literature, which this summer I actually went in and read Bowlby's original books, read through them, which I had never done. is that for me, the kind of human being I want to be, skip work, is a kind of human being that is able to be present with people, to be available, responsive, accessible and responsible to two things Bobby said. And I want to be a healing influence. So that makes sense to me at my home first. That's how I want to be with my family. Then second, that makes sense to me if I go back over 16 years of clinical practice, think about the best moments in therapy. It's usually where someone connected with another person, which is hard to facilitate in individual therapy. And those moments, whether you call them softening moments or use any other language you want to use, it's all about connecting with another human being in a safe and powerful way. So for me, if that's the Mecca, if that's the place that I want to live in and what I want to facilitate, then I need to do all the research I can to figure out what makes that happen, what prevents that from happening, why that's important. And then for me, I really do take a biopsychosocial approach, which is that moment impacts us on multiple levels, and biology is just one of them. But to be honest, what are the outcomes people care about? I can do all this MFT outcome research, but people care about, are you get sick or healthy? Do you do well at work or lose your job? And do you stay married or get divorced? Because those things have huge societal costs.
Societal, economic, and emotional.
And I think attachment's related to all three of those. We're doing some other research right now that says the quality of your relationship impacts how satisfied you are with your work. And if you tap into the literature of the business world, work satisfaction and work productivity are like this. They're just one-to-one. So EAPs and all these things are based on the idea of we're losing tons of money. And I don't care how you do it, but get these people happier at home and less depressed, because then it helps me at General Motors.
Right.
So, I mean, those are things that matter to me. And I think are areas where other people have done the research for us. I'd like to see MFTs do that research.
I think one of the things that you've just explained is that you can be involved in clinical research without having to adopt a manualized approach.
No, you don't have to.
Because you've identified more of a paradigm, saying this is the claim that I make as a couple and relationship therapist, as a marriage and family therapist. I'm emphasizing intimacy and connection with people.
Yeah.
And then anything that I do that contributes to intimacy and connection, any research that I do helps move the field along, helps give us greater understanding.
Yeah, I couldn't agree more, and there's at least two ways to do it. One is get into the therapy room and figure out what's happening, which Brent Bradley and other people have done a great job. What happens in those moments of therapy? Or I just read an article on the way out in the Journal of Clinical and Consulting Psychology, which is hard to get into for us, about the best moments of attachment, injury, healing by Judy Mackinnon and Sue Johnson. So that's one area that's very clinically focused, using tapes from sessions, interviewing folks, task analysis, content analysis. But the other area that I think is clinical research, which is debatable, some people debate, is that the research on the basic processes of therapy that are therapeutic and healing. And that's really where I'm spending most of my time right now.
So is that also therapeutic alliance, or would you differentiate it from that?
See, the funny thing about that is that really what it says is that my alliance with them only matters in facilitating their connection. That I think what's different about EFT and some other things is that is only a tool. It's not the healing agents. The healing agent is what happens between them in session.
External to the therapist.
But I have to have that alliance to facilitate that. It's important. But it's not the change agent.
Yeah.
Now, that's why I don't like individual therapy very much.
Yeah.
Because I think it's non-permanent change. I mean, you can help someone address a wound and an injury, or you can help someone address an injury and a wound and be comforted by a significant other who will be in their life 6 months from now, and I won't be.
Right.
So I shouldn't be in their life 6 months from now.
You've been in your career 14, 15 years or so as an MFT educator, and recently went back to, with the last three years or so, you went to training.
Yeah, I did.
So there's probably people watching this right now going, holy cow, what do I have to, I get my PhD, I grind it out in grad school, and I have to get additional training.
Yeah.
Can you talk a little bit about the decision you made to get additional training?
Sure.
Because there are some people who think, once I've got the PhD, I've arrived, and I've got it nailed down.
To be honest, Steve, I've been an active clinician since I graduated, anywhere from, on a low side, 30, on a high side, 60 hours a month of clinical work. So I've been clinically active. I think